Πριν παρουσιάσω τον κύριο Ζέγκο, απλά να πω κάτι κι εγώ. Δέσποινα, καλές είναι οι οδηγίες, αλλά η λέξη LGAD στη μαγνητική, σαν risk factor, είναι πολύ γενική. Εξαρτάται από την έκτασή της. Δεν μπορώ να δεχτώ απολύτως τον όρο αυτό. Όπως γράφει. LGAD μπορεί να είναι ελάχιστο. Μια και μας ακούνε έτσι οι συνάδελφοι, εγώ ήθελα να πω ότι από όλες τις αριθμιογόνες μυοκαρδιοπάθειες, αριθμιογόνες διατατικές, εκείνη που κατά κύριο λόγο έχει τα βαθύ minor T-wave changes, as Professor McKenna said, είναι η filament C. Αν δούμε πολύ χαμηλά δυναμικά και αβαθή αρνητικά τάφ, κυρίως στις πλάγιες αγωγές, πρώτα να σκεφτούμε τη filament C και μετά τη δεσμοπλακίνη. Τώρα να καλέσουμε Dr. Ζέγκος is going to present the next case. Θωμά, σε 12 λεπτά πιστεύω να τελειώσει.
Θα είμαι σύντομος, κύριε Θημιάδη, ναι. Καλημέρα σας και από μένα. Ευχαριστώ το Προεδρείο, τον κύριο Θημιάδη, την Οργανωτική Επιτροπή. Εγώ από την αριθμιογόνο θα περάσουμε τώρα στην υπερτροφική μυοκαρδιοπάθεια και θα παρουσιάσω δύο περιστατικά. Okay, I'll try. Okay. Well, I'll try to speak in English. I'll present two cases which have mutations in gene ALPK3, a gene that was associated with hypertrophic cardiomyopathy during the last years, a new gene, and that really shortens the knowledge gap in the genetics that we already know in HCM. So we have a male, 25 years old, when we saw him the first time, and he was referred to a cardiomyopathy clinic due to diagnosed HCM. The age of diagnosis was 9 years old, and he was treated from a pedocardiologist. The reason for diagnosis was simply a murmur at a random checkup. He was asymptomatic, New York Heart Association class 1. He didn't receive any medication, and he had a family history. He referred a family history. He reported the family history negative for cardiomyopathy or sudden death. You can see his family tree. We clinically examined his parents and his siblings, and they didn't have any phenotype. We didn't have the genetics testing, the possibility for genetic testing then. It was many years ago. You can see his ECG, sorry for the quality. It's quite abnormal ECG with right axis deviation, a short PR interval, a long QTAF, it's about 500 milliseconds, and LVH. You can see a CMR that we received from the patient. It was performed when he was 20 years old. Sorry for the quality also. You can see the hypertrophic IVS, the trabeculosis at the lateral wall, okay, and a relatively preserved. I could see ejection fraction. You can see from the short axis too. And you can see the late gadolinium enhancement, excuse me, at the hypertrophied IVS and the insertion points from the short axis. And you can see the first echo that we did in our clinic. You can see a depressed ejection fraction, concentric hypertrophy, 5 years after the CMR. You can see that the ejection fraction is about 40-45%, hypertrophy of the right ventricle, normal systolic function of the right ventricle. However, it's deteriorated from the CMR that the patient showed us. The ejection fraction. You can see the diastolic function is pseudonormal and normal pulmonary pressures. The Holter that the patient that we performed was normal, and the laboratory findings. The patient had normal renal function, normal CPK, normal liver enzymes, and we performed a testing that we had, due to the short PR interval and the deterioration of the ejection fraction, we thought maybe to exclude Fabry disease, and it was negative Fabry disease testing. So we initiated heart failure therapy for the patients, and we referred him for ICD implantation due to the low ejection fraction and because he was really young. 1 year later, the patient has deteriorated clinically. He was in NIHA class 2, 3, and he reported dyspnea. You can see his ECG, it's the same, nothing changed. However, you can see the echocardiography deteriorated from the short axis. The apex doesn't move at all. You can see his ejection fraction is about 30%, the most. And the right ventricle also deteriorated. The systolic fraction of the right ventricle also deteriorated, and you can see there is a mass here, like thrombus, possibly thrombus, to the still apex. The diastolic dysfunction is grade 3 now. It's a restrictive pattern. The pulmonary pressures remain normal. The Holter also was normal. We performed the cardiopulmonary exercise testing, and and the patient had reduced exercise capacity with a maximal oxygen consumption of about 47%. So we continued the heart failure treatment. We added anticoagulation due to the thrombus we saw, and the ICD was implanted. 6 months later, the patient suffered a stroke after ICD implantation without an AF from device electrograms. However, 1 year later from our last follow-up, when the patient was 25 years old, the patient was hospitalized due to congestion. You can see his heart is really, really deteriorated. You can see that there is an LVD shape, mainly due to the increased RV volume. You can see that nothing moves. The ejection fraction is about, 10%. You can see he had a very rapid deterioration of the LV function and the RV function. So we referred him to transplantation center. He was one of the 3 patients that Mrs. Parcharidu mentioned that was transplanted at our center, at Gnosios Center. You can see his heart after transplantation. Okay, a normal heart. After the transplantation, we performed genetic testing to the patients because then we had the opportunity to do it, and there was a frameshift mutation in ALPK3 gene, and the patient was homozygous to this mutation, and we analyzed his parents, which were heterozygous. However, they didn't have a phenotype, and we are awaiting the genetic testing of his siblings that also don't have phenotype. So we have an homozygous patient to a frameshift mutation in ALPK3. Second case, a patient without symptoms, NIHA class 1, family history reported negative for cardiomyopathy or sudden death. He came to our hospital for cardiac arrest. After cardioversion, we can see his ECG. We can see that he also has a short pair interval and repolarization abnormalities at the precordial leads. We can see his echo. It's common, I think, mixed apical hypertrophic cardiomyopathy. Okay, you can see the cavity closure at the apex. You can see from the short axis to the hypertrophy at the apical segments. So we genetically tested the patient, and he also had a frame-shifted mutation in ALPK3. However, he was an heterozygous. He had it heterozygous, and he had apical phenotype. We saw his brother, and he also had HCM phenotype, and his father, which also had HCM phenotype, and also were heterozygous in this frame-shift ALPK mutation. His son and his nephew were also had also the mutation. However, they didn't have a phenotype. Let's go to see his father. You can see his ECG. It is abnormal. We have negative T waves at leads V2, V5, and you can see the echo has the same picture with his son, a mixed apical HCM. His Holter was normal. And his brother, we can see his ECG, also abnormal ECG with negative T waves at the lateral wall. And we can see the echo, which also has HCM phenotype, and you can see the increased trabeculosis, especially at the apex, and cavity obliteration at the apex. The Holter was also normal. So we have two different cases, one patient with homozygous frame-shift mutations in ALPK3 genes, and a family with heterozygous, which were heterozygous in frame-shift mutation in ALPK3. Different patients, different phenotypes, one heterozygous, one homozygous. Two words about ALPK3. ALPK3 was associated with HCM in 2016, if I am not wrong. There are two mechanisms proposed for this association. First, ALPK3 is considered to be a regulator of transcription factors of proteins of the desmosome. That's, I think, why there are two patients in the literature that have HCM phenotype with ALPK3. So we have an impaired desmosome, which we know the role in myocyte linkage. And we have disrupted, we assume that we have disrupted a function of desmoplakin and plakoglobin. Also, through WNT signaling, we have subendothelial fibroblastosis and intercalated disc remodeling. This is the first mechanism proposed for ALPK3. However, also, ALPK3 seems to stabilize myomesin in the nuclear envelope and in the M band. And so it is supposed that as a stabilizer of myomesin in nuclear envelope, in homozygous patients, it leads to depressed LV function or later in HCM, and in heterozygous patients or late stage of homozygous patients, leads to hypertrophic cardiomyopathy due to the destabilization of myomesins in the M band of the sarcomere. The first report of biallelic truncating mutations in ALPK3 were reported in 2016 in 7 patients, early cardiomyopathy, severe cardiomyopathy, with hypertrophic cardiomyopathy, most of them, or dilated, 2 of them dilated cardiomyopathy. From the same patient series, 19 patients were reported in 2020, and we have 4 homozygous ALPK3 patients, and we have some specific characteristics. First of all, most of the patients were diagnosed at very early age, like our first patient. Second, 44 of the patients have had DCM which progressed to hypertrophic cardiomyopathy. 80% of the patients had prolonged QTC interval, like our first patient. And 50% of the patients had extracardiac manifestations, which our first patient, which was homozygous, didn't have extracardiac manifestations. However, in this case series, it were reported that it also analyzed 39 adult HCM patients which carried loss of function, heterozygous ALPK variants, and it was found that 2.5% of them carried heterozygous LPK variants. And the main study that I want to say to you, it's from Luis Lopez in 2021, which analyzed 770 HM patients and used a validation cohort of 2,047 HM patients and found that 1.5% of probants had truncating LPK3 variants with specific characteristics. 69 of them had LVH criteria in ECG, 10% short paired interval, like our second patient, our second family. Most of them had apical or concentric LVH, statistically significant different from sarcomer or non-sarcomer HCM. Systolic dysfunction was present in 6% of the patients and excessive fibrosis in 50% of the patients. 7% of the patients died of heart failure or had heart transplant. This was statistically significantly different from non-sarcomer HCM and numerically a higher percentage than sarcomer HCM, however, without statistical significance. So, to conclude, we have the homozygous truncating variants of LPK3, which cause early onset cardiomyopathy and often detected in non-European regions, in the Asians mainly. Heterozygous LPK3 variants, which, as I said, they are associated with late onset apical concentric hypertrophy and risk of heart failure. And we suppose that the other null variants of LPK3 act as regulators for the penetrance of wild type or pathogenic variant of LPK3. So, novel LPK3 mutations are associated with HCM. Homozygous phenotype is associated with early onset cardiomyopathy and usually with extracardiac manifestations. And heterozygous genotype has high prevalence of specific phenotypic features and is associated with heart failure, statistically significantly different from non-sarcomer HCM patients. Thank you very much, and sorry for my English.
Very nice. The time is going, so I would like to have some brief comments from Professor McKenna and Franco Cecchi, if Franco is listening. Bill, have you any comment?
Yeah, so, I mean, first of all, well done on the English. Being told in the middle of your talk, speak another language, well done. That's happened to me when speaking French. Alpaca 3, I mean, if you're Franco, Dr. Cecchi and I have been looking at hypertrophs for 35 or 40 years, and what would we have said 30 years ago? Definite diagnosis, and some of them proceed and are fine until they're 80 years old. Some of them die suddenly. Some of them get heart failure. That phenotype, it comes back to the hypertrophic phenotype is not a diagnosis. It's a phenotype, and you need to work out what the gene is, because the genes are different and the genes cause different diseases, as we've seen even this morning. So very nicely presented. Here is a gene that we don't really understand very well. It's a regulatory functional gene that clearly impacts, but the management needs to take into account, you know, this is different than troponin T. This is different than myosin binding protein C. So you need to know the gene. The Luis Lopez paper that came from clinical cohorts collected by Luis, but the data, the genotyping was done at Health and Code, and Juan Pablo Ochoa is a Argentinian who was a lead on this paper, and the phenotypes are really quite variable. And if I understood, did you say short PR or long PR? Short PR. Yeah. So again, there's so many little things here, but a short PR that's consistent is highly suggestive of a storage AMP kinase. It's a storage, it's a posterior AV nodal pathway. It's not a conventional pathway, which gives you the short PR. There's a lot of things here related to the desmosome, to the metabolic component, the regulatory component that we don't fully understand. But you do. It is important to actually get the gene because it tells you we're in a no man's zone. We don't know. This isn't C protein or myosin. So, but anyway, very well done. And personally, I have very little experience of this. I don't know, Franco, if you've seen it a lot or not.
Well, I haven't seen yet. Really, maybe we have one case, not more than that. But I mean, we just started a short time ago to look for ALPK3, and I was amazed by this case, and above all, I'm amazed by the fact that in over 50 years, of investigation, now we finally understand much more of what's going on. I remember when Bill was telling us about troponin, young people dying suddenly with very small hypertrophy, and that was really, something peculiar. But now, we finally understand. So, medical students and young doctors now finally have the tools to understand better what to do and how to manage these patients. Let me just comment one moment about the first slide, when he said that he investigated Fabry disease. And I believe that this was not correct, because no Fabry disease shows up in males just at that young age. The first case that I'm aware of was a 25 years old young man with just mild hypertrophy. So that was just the only comment I could make on the slide. I would immediately, with our knowledge, thought of Danon disease in this case. So young age, male, but I believe that this was investigated early, and probably it was zeroed out, I guess. So that was my impression at first. But my compliments again, Yorgos, of the work that you've been doing so far. Here in Thessaloniki, and of the results that you really had. Really, I'm impressed.
Thank you, Franco. I really am very depressed because you are absent.
I'm really sorry. Waiting 3 hours in the airport, and we couldn't do anything. This.
I know. I know.
They are scared of a snowstorm, and they don't fly at that time. So I'm really sorry. I'll come back anyway. Okay. We make it as a plan.
You know how much we love you, Franco.
Yeah.
Yes.
So this alpaca 3 case is a great example. Franco and I used to be experts.
Yeah.
Now, and an expert is someone who knows what he doesn't know, and we know what we don't know, and we're learning.
Yeah.
So thank you.
Exactly.
Okay, so we're carrying on, and